Hello, everyone. A warm welcome from the Australian National University here in Canberra. I hope you and your loved ones are keeping safe and healthy. My name is Dipti Talaulikar. I'm the program lead for the Global Peer Support Program at ANU. Joining me today are Jay Poria, the Manager of International Relations and Partnerships here at ANU, and Devashi, a medical student who is volunteering with the program. I'm delighted to welcome our speaker today, Associate Professor Sanjaya Senanayake. He is an ID physician and the director of the ID department at Canberra Hospital. Sanjaya has a strong interest in infections of public health importance and has been a regular presence in the media during the COVID-19 pandemic. Joining him today are Dr. Surbi Madan, Head of Department of the Infectious Diseases at the Care Institute of Medical Sciences in Ahmedabad in Gujarat. I'd like to acknowledge the Gunawal and the Gambri people who are the traditional owners of the land where ANU is located, where we are broadcasting to you today from, and I pay my respects to their elders past and present. Many of you are joining us from various parts of Australia and the globe, and I would like to acknowledge the traditional owners of all those lands and pay respects to their elders past and present.
Look, thank you, Deepthi, for the kind introduction. Thank you, Dr. Madan, for joining us from Gujarat. It's really important. I am going to talk about mucormycosis in India, but just on the basis of what I've seen in the literature, that, of course, is nothing compared to the wealth of real-life experience that Dr. Madan has, and I'm actually looking forward to hearing about her experiences with mucor in India. But you'll have to tolerate my few slides where I'll just talk about what I found in the literature. So I'm an infectious diseases physician here in Australia, and mucormycosis is an infection that terrifies us and challenges us, but not as often as it does in some parts of the world. So I'll be talking about the infection in general. So its pathogenesis, its epidemiology, its etiology, clinical syndromes, diagnosis and treatment, mucormycosis in India, briefly talk about secondary infections in COVID-19, and briefly talk about mucormycosis in COVID-19. So the reason we're doing this talk today primarily is because of the surge of mucormycosis that we've heard about in the international press associated with India's large wave of COVID-19. So you can see the South China Morning Post there, and these two photos from a BBC article. And in fact, just before we started, I was asking Dr. Madan the label mucormycosis ward, whether it was pre-COVID-19 or because of COVID-19. It apparently was because of COVID-19. But in a country like Australia, where we see so little mucormycosis, the concept of actually naming a ward after mucormycosis is mind-boggling. Just the extent of mucormycosis in India is just mind-boggling. The other thing which is interesting is none of my colleagues and I had ever heard of mucor being called the black fungus before we heard of it in the media. So what's the black fungus? And of course, then when they started talking about mucormycosis, we figured it probably is because of the eschars that occur with particularly rhino-orbital disease, the sort of black palatal or the black skin lesions that you see. But Dr. Madan can certainly comment on that as well.
I agree with you, Dr. Sanjay. I think it's mainly related to the necrosis caused by the fungus, which is actually, ultimately gives blackish discoloration to the necrotic parts.
Wonderful. Thank you very much. So heading to the microbiology, mucormycosis, it's a filamentous mold within the orders of Entomophthorales and Mucorales. There are lots of genera within the mucormycosis order. So the most common is Rhizopus, and particularly Rhizopus oryzae is the most common species of mucormycosis we see with clinical disease. Then in terms of other genera, Mucor and Lichthemia. They're the three most common. The less common ones Apophyomyces, Rhizomucor, Cunninghamella, Saxenia. And Cunninghamella is often associated with a worse prognosis. Like most molds, like Aspergillus, etc., they're environmental. They're found everywhere. They're ubiquitous. That's why mucormycosis is a global disease, even though it's worse in some places than the others. So it's found in the soil, the dust, bread, decaying vegetable matter. And I like to think of the main portals of infection as being the 3 I's. So inhalation, ingestion, inoculation. And the other feature of it is it's an angio-invasive mold. It invades blood vessels. So we'll talk a little bit about the pathogenesis because it's quite interesting actually. So normally when we encounter these ubiquitous molds in the environment, we inhale the spores, the sporangiospores. Then the defense mechanisms in our respiratory tract address them. So the cilia make sure that they're pushed down into the pharynx, and from the pharynx they go into the gastrointestinal tract. And then they're cleared from there. So that's what normally happens. And for infection to occur, you need those sporangiospores to germinate into hyphae. But what tends to happen, if you are not a diabetic, if you've got a pH that is not acidic, we have shown in vitro that the serum of that individual inhibits the growth of Rhizopus, the most common genus of the Mucorales order that causes human disease. In terms of increased risk, well, neutropenia. So certainly in Australia, where we see it with hematology patients, that is the big risk factor. So neutropenia is a key risk factor in the pathogenesis of mucormycosis. Even AIDS, where there's a lymphocyte deficiency, so low CD4 cells, there is an increased risk, but nothing compared to, say, that of being neutropenic. And this is because polymorphonuclear phagocytes, mononuclear cells, they use oxidative metabolites and defensins to kill mucorales. So they're very good at doing that. And if you have badly controlled diabetes, if your blood sugar is very high, if you've got ketoacidosis, suddenly those phagocytes don't work so well. So that is a survival advantage for mucormycosis if you're hypoglycemic with ketoacidosis. And there are some other things about ketoacidosis which we'll talk about shortly. So siderophores, you're probably familiar with the name. So siderophore is a molecule that binds iron and presents that iron to a microorganism. Because all living creatures, even big ones like me, or little fungi or bacteria, we all need iron. So siderophores help microorganisms get iron. Now, sometimes the microorganisms, the fungi can be, bacteria can be very clever. They can use our own siderophores to get iron. And when they do that, it's called a xenosiderophore. And mucormycosis is capable of doing that. So what you don't want in your body when you've got mucor inside your bloodstream or in your body is free serum iron. You don't want that because the mucor will take it. It needs it. So the ferritin, transferrin, lactoferrin we have in our bodies, which bind iron, protect us. And it's been shown in studies, if you have serum that does not have iron in it, Rhizopus oryzae, the most common species that causes clinical disease, doesn't grow well. Another really interesting fact, diabetic ketoacidosis, I said I was going to mention that. It is associated with more free serum iron. So if you've got ketoacidosis, you've got the hyperglycemic effects, but you've also got more free serum iron for the mucor to gobble up and become stronger. And the iron binding capacity of the ferritin, the transferrin, the lactoferrin we're talking about, all of that is reduced in acidic conditions, such as diabetic ketoacidosis. Now, interestingly, there are some chelating agents like deferrosirox, deferiprone, which are non-siderophores for mucorales and actually protect against the fungus. But it's not uniform. Cunninghamella, which I said can be associated with worse outcomes, is a bit more resistant to that. So a very common chelating agent, deferoxamine, which is used quite widely, well, we see it used in dialysis patients, for instance, because people with chronic renal failure and on dialysis they're prone to iron overload, to hemosiderosis. So if they're given chelating agents, it is actually very advantageous to the rhizopus. It uses the deferoxamine as a xenosiderophore and uses it to bring iron to itself. So the deferoxamine takes the ferric iron from transferrin and attaches itself to the rhizopus, which is and transports the iron into the organism itself. Now, if you look at the capacity, the iron binding capacity of rhizopus compared to some other pathogenic fungi, we find that it's 8 times capable of incorporating 8 times more iron than Aspergillus fumigatus and 40 times more iron than Candida albicans. And another scenario where we see this is with iron overload from repeated blood transfusions, for example, in myelodysplastic patients. And of course, the other issue with myelodysplastic patients is the double whammy, is that they're often neutropenic for very long periods of time. Rhizopus oryzae also has its own siderophore called rhizoferrin, but it actually isn't good at taking iron from human serum. Now, there are other methods of this organism getting iron. They've got their own permeases, which is a reductive system that turns ferric iron into ferrous iron that's more soluble. Even using heme, Rhizopus has got some heme oxygenases, which might be able to take iron from hemoglobin and could explain why it's angioinvasive. It has that predilection to look for blood and extract iron from hemoglobin. There's another gene, the SREA gene, which is a transcription regulator. And there are 2 orthologs which probably encode for ferritin, but we're not quite sure. In terms of angioinvasion, when that happens, we get a lot of thrombosis and tissue necrosis. And that's very important, a very important means of this organism causing damage in humans. And the angioinvasion, of course, allows the organism to disseminate. And disseminated mucormycosis has a very bad prognosis, as you might imagine. And one reason we think it's so effective at angioinvasion is that it uses a GRP78 protein to get into endothelial cells, to incorporate itself and invade endothelial cells. And in fact, in mice with diabetic ketoacidosis, if they're given anti-GRP78 immune serum, it's protective against invasive mucormycosis. There are some other virulence factors. There's rhizoxin, but that seems to be more important for plants than humans. Lytic enzymes. There's a ketone reductase system. But one I just wanted to really talk about was voriconazole. Now, voriconazole is a triazole. It is a very effective antifungal agent that we use a lot. It's very good against Aspergillus, but it has no inherent mucorales activity. So you can't use it to treat mucormycosis. So one reason you might see mucormycosis in someone on voriconazole prophylaxis is because it's been selected out, because voriconazole has killed or protected against other fungi such as Aspergillus and allowed resistant fungi such as mucorales to appear. But interestingly, voriconazole also appears to be able to increase the virulence of mucor. So a study was done with Drosophila flies and mice where they took a whole lot of strains of zygomycetes, so mucor, and they exposed some strains to voriconazole, some not to voriconazole, and then they inoculated the flies with them. And in the flies, you got a hypervirulent strain of Rhizopus only when it was exposed to the voriconazole. And in the mice who got that Rhizopus that had been exposed to the voriconazole, there were decreased survival rates and increased pulmonary burden. And if you look at it the other way around, they also treated some of the Rhizopus with other antifungals like amphotericin B, itraconazole, caspofungin. But there was no emergence of a hypervirulent strain of Rhizopus when that happened. And interestingly, when you did the same experiment with Aspergillus fumigatus, the pre-exposure to voriconazole didn't lead to the emergence of any hypervirulent strain. So voriconazole induces virulence. So that's really interesting concept. So if you look at the incidence, this is a pretty rare condition in children. It certainly can occur, and I believe particularly in neonates, GI presentations can be quite common, but it's certainly not a common presentation in children. And again, Dr. Madan at the end could tell us if she has seen a lot of pediatric mucormycosis. In all parts of the world, or many parts of the world, the incidence is increasing, especially in France, Belgium, Switzerland, and India. And in India, in France, from over a 9-year period, at the start of this century, they found 35,876 invasive fungal infections, of which only 1.5% were due to mucormycosis. But the incidence has increased from 0.7 per million to 1 per million in a 9-year period. And in Spain, we've similarly seen a rise, more than a doubling in recent years. Now, in mucormycosis in places like Australia, where I am, it's almost always in immunocompromised people. And it could be just because there are more immunocompromised people here, rich countries with easy access to better diagnostics. And we talked about this before with voriconazole. We use mold prophylaxis such as fluconazole or voriconazole, which are to which the mucorales or mucor is resistant. So in very broad terms, the epidemiology between the developed world and, say, India and other parts of the developing world, there are hematological malignancies that dominate as the association with mucor in the developed world. Now, in Australia, for instance, an 8-year study between 2004 and 2012 was done, which identified about 50% of cases associated with hematological malignancy. The incidence, we're going to talk about that now in the next slide. It's so much higher in India than in many parts of the Western world. And there's a lot of rhino-orbital cerebral disease. Whereas in the developed world, you do see that, but you also see a lot more pulmonary disease. So if we look at the global epidemiology, now I'm here in Australia. I'm in Australia where the incidence is about 0.06 cases per 100,000 people. And in that study that I mentioned between 2004 and 2012, there were only 70 odd cases of mucor found. Whereas if you look at India, it's about 14 per 100,000. And the same with Pakistan. So that's about 200 times, over 200 times higher than the incidence in Australia, which is quite extraordinary. The risk factors, there's diabetes mellitus, hematological malignancies, organ transplantation, autoimmune disorders. So in Australia, rheumatological conditions, autoimmune disorders accounted for 12% of the burden of disease we saw, even though the absolute numbers were small. And then immunosuppressive therapy, HIV, iron overload, burns, trauma, dialysis, peritoneal dialysis, malnutrition, and previous voriconazole. And again, if you look at this slide, which looks at the breakdown of the etiology of the disease, you can see in India that, or etiology of risk factors, I should say, or the etiology of disease and the risk factors. In India, diabetes is very prominent. In Australia, where I am, diabetes isn't a big risk factor, and hematological malignancy is more important. So hematological malignancy is the most common underlying disorder for mucormycosis in the US and Europe, accounts for about 38 to 62% of cases. We contrast that to places like India and Iran, where it's well under 10%. Now, solid organ transplantation only accounts for a small proportion of mucormycosis cases. And typically the risk factors associated with that are renal failure, diabetes, prior antifungal prophylaxis, which is a common theme that we're seeing during this talk. So caspofungin or voriconazole, and corticosteroids, which impair macrophages or neutrophils. They're the risk factors we look at. Diabetes, in India, it's the most common risk factor, as we saw in that previous slide, over 50% versus 36 to 40% in global data. In Europe, it's about 17 to 29%. Again, Iran, where we didn't have much hematological malignancies as a risk factor, has a very high risk factor association with diabetes, with 74%, and Mexico 72%. And interestingly, diabetes as a risk factor is more of an issue in North India than South India, and maybe Dr. Madan can comment on that later, and that could be a genetic issue, a dietary issue, lifestyle issue, so there could be a number of factors associated with that, but I don't know. So there was another interesting study which came out in 2007, or paper, which noticed that in developed nations, they're seeing less mucormycosis despite seeing an increased prevalence of diabetes. And the author, who's quite an eminent antifungal doctor, concluded that statins, which are used for cholesterol, may in fact be the reason, because they have in vitro and in vivo inhibitory activity against mucormycosis. But I wonder, again, in India, I'm sure, like Sri Lanka, where I'm from, there are a lot of people who are on statins. And I don't know if statins is the whole story here. In HIV patients, I said HIV, it wasn't a big risk factor, but we certainly see some cases. And when it occurs, it tends to be injecting drug use, periods of neutropenia, concurrent corticosteroid use, which by them, the corticosteroid use by itself and neutropenia by itself are, of course, big risk factors. And you just see a mixture of disease disseminated, renal, which is interesting, and rhinocerebral. We'll talk about renal in a bit. And the mortality is about 50%. Now, we've talked about this being a disease of the immunocompromised, which it predominantly is, but immunocompetent people also get mucormycosis, but usually it's cutaneous. So there's been some sort of portal of entry through the skin, be it surgery, burns, trauma, an injection, a contaminated dressing, and cutaneous mucor can occur. Now, even in immunocompetent people, it can be a very serious aggressive infection, but with early surgery and therapy, they tend to have pretty good outcomes. But you can get severe disease, including acute necrotizing skin and soft tissue infection. So the clinical syndromes you get with mucormycosis, there are a few: rhino-orbital cerebral, pulmonary, cutaneous, gastrointestinal, disseminated, renal, and other. Like every infection that we know about, particularly a lot of bacterial infections, they have certain common presentations, but they generally can do anything. So in terms of a breakdown of percentages, now rhino-orbital cerebral and pulmonary seem to dominate, with cutaneous not far behind, and disseminated can also be a problem. So rhino-orbital cerebral is more common in poorly controlled diabetes. And in fact, if you've got poorly controlled diabetes and have a dental extraction, that can be associated with an increased risk of this horrible condition. And the symptoms will vary according to what part of the nose and the face and the eye is involved, but it's often very painful. It's a horrible condition. There can be fevers, there can be eschars on the palate, chemosis of the eyes, proptosis as the disease progresses, and surrounding cellulitis. So you can have a myriad of symptoms according to what part of the face is involved. And Rhizopus oryzae is very strongly associated with this kind of presentation. This is from the Lancet Infectious Diseases, a series of images, and apologize if they're a bit disturbing, particularly E. This is a young child with ALL, who developed rhino-orbital cerebral mucormycosis and unfortunately had a lethal outcome. And you can see the eyes are involved, the palate here, externally, the nose and the eye. And here's that black eschar. We talk about the black fungus. But it is worth noting with C and D, they had only been symptomatic for about 7 or 8 days. So this can be quite rapidly progressive. Pulmonary disease is the one that we see the most in Australia, and even then it's not that often. And when people present, certainly with the hematology patients, the main symptom is usually fever. they often have very little or no respiratory symptoms. Now, eventually, if we didn't treat them, they could progress to get a number of symptoms: shortness of breath, hemoptysis, that's another common symptom as well. But we often just see them when they've had a fever that isn't responding to broad spectrum antibacterial antibiotics. And as you can see from here, you can get a variety of different features: bronchopleural fistulas, necrotizing pneumonia, and a couple of fatal conditions: fatal aortic rupture, fatal hemoptysis when a blood vessel has been eroded into. And in lung transplant patients at the anastomotic site, you can get ulcerative tracheobronchitis, although that is more common with Aspergillus. Now, to tell the difference, now in hematological malignancies, Aspergillus is the most common invasive fungal infection we see. Mucor is less common. Are there ways to tell them apart? Well, Mucor is more likely to have pleural effusions, more likely to have greater than 10 pulmonary nodules, have the reverse halo sign, and similarly also have a solitary lesion. So many lesions, or maybe a solitary lesion. The halo sign I'll quickly talk over. So it was first described in acute leukemia and invasive pulmonary aspergillosis. So what it is a ground glass opacity surrounding a solid mass, and it reflects infarction with an area of surrounding hemorrhage. Now, it's an early indicator of invasive pulmonary aspergillosis. Some say at about day 0 or 1, some studies have said it's about over 90% sensitive. So it can be a very useful tool. Now, as you can see on this side, there are a number of conditions associated with it. Whoops, I did it again. A number of conditions associated with it. But in the setting of a febrile neutropenic patient with a hematological malignancy, it can be very sensitive for an invasive fungal infection, and very specific, I should say, for an invasive fungal infection, particularly aspergillosis, but also mucormycosis. And this is the halo sign. So you can see that solid lump, nodule, infarction with infarction, and that little halo of ground glass changes around it. Then there's the reverse halo sign. So as it implies, you see a central ground glass opacity with a denser area around it. So it's a reverse halo. And we think that's infarcted lung tissue with greater hemorrhage at the periphery than at the center. Now, it was first associated or described with cryptogenic organizing pneumonia, and it is the most common cause of cryptogenic organizing pneumonia, is the most common cause of the reverse halo sign in immunocompetent patients. But in immunocompromised patients, the most common cause is mucormycosis. So if you see an immunocompromised person with the reverse halo sign, think mucor. And there it is. In this one, you can see the dense halo outside and the ground glass area within. So cutaneous disease, as I said, immunocompromised people can get it, but it's one of the more common presentations, or the most common presentations with immunocompetent people. And it can spread rapidly, but often has good outcome. A French study looked at 16 people who had cutaneous disease after trauma, and 85 who had non-traumatic cutaneous mucor. And they found that the post-traumatic cases were more likely to have a cutaneous localization, which makes sense, a rarity of underlying disease, and a shorter time before diagnosis. Quite a big difference. And the most common organisms were Apophysamyces elegans and Saxenia. This is a really unusual condition that's only really seen in India and has been seen a little bit in China. And again, Dr. Madan's thoughts on this would be very interesting. Isolated renal mucormycosis. We do not see this in Australia. So the kidney is involved in 22% of disseminated mucor cases, but pure isolated renal mucor is rare. There's been one case series from China, but otherwise all the cases are from India. And interestingly, the Indian hosts were healthy, so they were immunocompetent, although the Chinese hosts had some risk factors. It's a very non-specific presentation: fever, flank pain, hematuria. and on imaging, you have very unhealthy looking kidneys. And despite increased awareness and diagnosing it relatively earlier than in the past, it has a 50% mortality. And the portal of entry is unclear. Is it from the lungs or is it through the bladder? And if it's the bladder, how does it get there? And don't forget healthcare associated disease. So multiple outbreaks have been described. The sources being as diverse as wooden tongue depressors, umbilical catheters, bandages, other adhesive dressings. When it's occurred in that setting, it's mainly been cutaneous, but other forms have occurred. And this was a case in China. In over a 6-month period, 12 patients with hematological malignancies developed mucormycosis. And the cause was found to be contamination of allopurinol tablets and ready-to-eat food items. And they suspect that cornstarch that was used for both items was the contaminated original product. Then in a pediatric hospital, there were 5 children who had hospital-associated mucor who all subsequently died. And they found it in the hospital linen. So both very scary cases, actually, for such a dangerous organism to be so readily accessible in the hospital environment. Look, in terms of diagnosis, imaging is very important. So if you have rhino-orbital cerebral disease, MRI, CT, to look at the extent of disease, to help the surgeons to work out what they need to debride is very important. Biopsying, or if you can't biopsy pulmonary disease or bronchoalveolar lavage. Staining, now hematoxylin and eosin staining, you can see it, but there are other better fungal staining. And you want histology. If you have tissue, you just don't want to see the organism, you want to see it invading blood vessels. And it has a characteristic appearance. Mucor is non-septate or pauciseptate. It's got hyphae which are 6 to 16 microns wide. They can be up to 26, and they tend to branch at 90 degrees. So Aspergillus tends to be have skinnier hyphae and branch at about 45 degrees. But the reality is when you get tissue and you prepare a slide, you scrunch up the organisms, and it's very hard to appreciate those classical features. PCR can be done, and if it's available, that's fine. It's very specific, but it's got variable sensitivity. And of course, culture is very important. So that's those thick hyphae of mucor and the sort of thinner ones, the thinner septate ones of Aspergillus. Now, in terms of treatment brushstrokes, these are the broad principles I want to mention. There are no randomized controlled trials of note for this, unfortunately. Surgery, what we call in our unit, my colleague Peter Collignon uses the term scalpelmycin, a very important antibiotic where you get the surgeon to debride all the infected necrotic tissue. So scalpelmycin, our most important antibiotic, I suspect. Now, triazoles are mainly used as salvage therapy. As mentioned before, you can't use fluconazole, itraconazole, voriconazole, but a new triazole called isovuconazole has been FDA approved in the US to treat mucor in adults. Interestingly, while all the other azoles prolong the QT interval, isovuconazole shortens it. So that's an interesting fact worth remembering. Posaconazole is the other triazole which has some mucor activity. In terms of treatment, if you can reverse someone's risk factors, that is ideal. If they're on immunosuppression, if you can reduce that, that's wonderful. If they have poorly controlled diabetes, get that under control. High dose lipid formulation amphotericin, that is the first line treatment. So that is really important. And don't delay treatment. There was a study showing that if you delayed amphotericin treatment by 6 days or more, that led to a 2-fold increase in mortality at 12 weeks after diagnosis. So like bacterial gram-negative sepsis, time is vital with this condition. And lots of studies show that use your lipid formulation of amphotericin, not amphotericin B-deoxycholate, because in terms of outcomes, it seems to be much better. We were talking about iron chelating agents before. There's been one study, an RCT with a small one, where they gave amphotericin with deferocerox or with placebo for the first 14 days. Interestingly, the ones who got the iron chelating agent did really badly, but they suspect that could be because of the patients who were chosen. And just to remind you, if you're using voriconazole, posaconazole, and isovuconazole, there is a role for therapeutic drug monitoring. Look, in fact, not everyone's that clear about isovuconazole and therapeutic drug monitoring, but this University of Michigan site does have some data on it. So if you want to look at therapeutic drug monitoring recommendations, this is a good site to look. And this treatment guideline comes from this article, which is in the Lancet Infectious Diseases from 2019. And I think it's a very good one to look to. I won't go through it in great depth, but it's essentially saying use liposomal amphotericin B. This is what you do if you don't have liposomal amphotericin B. And this is what you do if you don't have the highly absorbable forms of posaconazole available. So I won't go through that in depth. And in terms of outcomes, 40 to 80%, there's a 40 to 80% mortality. It depends on the sites and morbidity. And as not surprisingly, if you've got disseminated disease, mucor everywhere, it's almost 100% mortality. But it's still very high for GI and pulmonary as well. Interestingly, in our Australian series of cases that I mentioned earlier, there was a very high mortality in those who had connective tissue disease. I'm not quite sure why that is. Maybe because we don't think of people with rheumatoid arthritis getting mucor, and maybe the diagnosis was made, there was a delay in diagnosis and treatment didn't start early enough. It's hard to know. Cutaneous disease tends to have the lowest mortality. Now, mucormycosis in India overall, this was an article from 2014, so before COVID. We've talked about a few things already about the very high incidence, that rhino-orbital cerebral disease is the most common form, that isolated renal disease is only really seen in India. There's high rates of nosocomial disease, 9%, and again from ECG leads, intramuscular injections, and dressings. And uncontrolled diabetes is the most common risk factor for all types of mucormycosis. And interestingly, Apophysamyces elegans seems to be the second most common agent after Rhizopus oryzae. Now, what about secondary infections in general in people with COVID-19? So a couple of months ago, this article made some headline news. This was between June and August of 2020 in the ICU and wards of 10 hospitals in India, looking at almost 18,000 patients. About 4% developed secondary bacterial or fungal infections, and that's consistent with a lot of studies which have found that it's been about 8, 10%, etc. But if you developed a secondary infection, your mortality was much higher than if you had COVID without a secondary infection, almost 60% versus 10%. And a lot of the bacterial organisms that were found were highly resistant, which is part of it. And this was around the time the recovery trial in the UK came out saying that dexamethasone is a life-saving agent for sick, hospitalized people with COVID. And if you look at the data from this article, in the respiratory specimens, Aspergillus was found. Interestingly, they didn't find mucor, which I found quite interesting given what we've been talking about today. There are a number of reasons for secondary infections in viral infections. So destruction of the respiratory epithelium, exposing the basement membrane, upregulating molecules that bacteria use as receptors, impaired function of macrophages by gamma interferon release by T cells, human coronavirus enhance adherence of pneumococci to virus-infected cell lines in vitro, and suppressed other types of interferon production, which compromises macrophage activity, and then affecting the gut-lung axis, and thereby gut homeostasis. And SARS-CoV-2 causes lymphopenia, which might also be another concern. In terms of a COVID-19 and mucormycosis, systematic review of the literature was published recently. Now, they looked at over 2,000 articles, and at the end of it, they excluded so many that there were only 30 left. And they found around 100 cases, and not surprisingly, 72% of the cases came from India. And but there were cases in other parts of the world. So this is not purely a phenomenon in India, although the majority of cases have been in India. Portugal is another country which has a very high incidence of mucor. I forgot to point that out on that slide, which showed the different countries. Portugal is a lot, but interestingly, they haven't reported any mucor from Portugal in the setting of COVID-19. And what they found in people who got mucor associated with COVID-19, the vast majority were male, 85% had diabetes, 86% had some comorbidity. Almost two-thirds of them had COVID at the time they got mucor, but about just over a third had recovered from their acute COVID-19 illness, which is interesting. Not surprisingly, most of them, when they had COVID, were really ill with COVID. It wasn't mild disease. And the median time between the diagnosis of COVID-19 and COVID-associated mucor was 15 days, but that went up to 90 days. And 85% used glucocorticoids, which we know is a risk factor by affecting phagocyte function and by increasing blood sugars. And rhinoorbital and rhinoorbital cerebral were the most common presentations, with rhizopus being the most common species, but we know rhizopus is the most common species with mucor anyway. Nearly everyone had surgery. The mortality was high, but compared to other forms of mucor, it wasn't much higher than that. And not surprisingly, if you had adjunctive surgery, it was associated with better outcomes. And it's also just worth remembering that SARS-CoV-2, like SARS-CoV, can infect and replicate in islet cells, which of course, the beta islet cells which produce insulin. So that can also impact on diabetic control. And cytokine storms, which we see with COVID, can worsen insulin resistance too. Good. So I think it's 8:20 now here in Canberra. So I've completed my talk. And I want to thank you all for listening. And I'll stop at the moment, and I guess we can answer some questions. But before that, if Dr. Madan could perhaps give her thoughts on COVID and mucormycosis in India and her experience, I would be fascinated to hear.
Thank you, Dr. Sanjay, for the wonderful presentation. I think you have covered most of the points theoretically. Now, regarding our practical experience in India, as you already mentioned, we have been we have been seeing it, the incidence as well as the prevalence. After COVID, we have seen almost twofolds more as compared to the pre-COVID era. Now, that study which you mentioned, that was a little earlier study, before the, I think around June to August. Now, we started seeing mucormycosis, COVID-associated mucormycosis, that is CAM, somewhere around September 2020. Before that, it was very sporadic cases. But that peak, that increased, the sudden increase which came was in the month of September. And then September to December was really bad. We call it as the first wave of mucor, which coincided with the first wave of COVID. And then there was a trough. And then we started seeing mucor again after April. So that coincided with the second wave of COVID-19 in India. But this time, again, the incidence as well as the prevalence has been much more as compared to the last year. We don't know what are the exact reasons. Of course, the main risk factor seems to be the glucocorticoid use. Because, last year people were not so confident in using steroids for the treatment of COVID. But slowly, it would not be wrong to say that a recovery trial came as a license for the people to use steroids in such a way that, the doses as well as the duration, that has not been properly controlled. That seems to be the major risk factor for CAM. Now, talking about the exact prevalence, so we did a retrospective multicentric study, and our center was a part of that study. That was done from September to December 2020. And what we found is that the overall prevalence of mucormycosis was 7%, and in the ICUs it was 1.6%. So it was significantly more as compared to the non-COVID associated mucormycosis. Again, the predisposing factors 62.7% of the patients in that study were uncontrolled diabetics, and around 20.9% patients were newly detected diabetes with CAM. COVID-19 was the only underlying disease in around 33% of patients. And of, around, so these were around 61 of 187 patients with CAM. And of these, around 13 patients did not even receive steroids. So that made us think that COVID-19 definitely is doing something to the immune system. So even without the use of steroids, people are developing mucormycosis, and these were very mild COVID, and around 17% of the patients were treated at home. So they were so mild in this study. So the sites, again, as you already mentioned, around 60% of the patients were rhino-orbital, and pulmonary was not very commonly seen with COVID-associated mucor, though we did see some isolated pulmonary mucormycosis, but it was not very common. And the most interesting, the most interesting thing which we saw in the post-COVID era is that the facial-maxillary involvement, that is the jaw involvement and the teeth involvement. Patients came to us with loosening of teeth and teeth falling down. That was very surprising for us, and we had to involve our facial-maxillary surgeons in almost all the patients of mucormycosis, which we have never done earlier. It was mainly ENT surgeons and neurosurgeons which were, doing the surgeries in in mucor patients. But this time, our maxillary surgeons have been involved like anything. Talking about the species, again, Rhizopus arisis and Rhizopus pusillus. These were the most common species. The others were Apophysomyces and Lichthemia. And yes, we managed these patients. Around 70% were managed with surgery and medical treatment combination. And in fact, a combination of surgery and medical treatment was an independent factor which was associated with good outcomes. Now, talking about the risk factors for mortality. So the overall mortality, 6 weeks mortality was around 38%, and 6 weeks mortality was around 45%. So it's almost similar, which has been described earlier in the literature. And age more than 54 years, rhino-orbitocerebral or pulmonary mucormycosis, and ICU stay. These were the independent risk factors associated with increased mortality rate. So these were the few points which we noticed till now. But what we have observed is in this time the incidence is significantly higher, as we have published in this study, and we are collecting our data. We are in the process of doing a case control study, and it's again a multi-centric study, and I think with the data will be soon out by in the next 2 months or so. That will give us an idea what were the major differences epidemiologically, the incidence last year and this year.
Thank you. That was really fascinating. And it is interesting, though, isn't it? Because we think that SARS-CoV-2 affects the lower respiratory tract and primes it for a secondary infection. Yet, as you said, hardly any of the CAM cases were in the lungs. It was all in the upper respiratory tract. And the teeth falling out, how extraordinary. That's bizarre. And I think, as you said, there were people who didn't receive steroids who got this. Perhaps the SARS-CoV-2 impact on the islet cells in the pancreas might have contributed to that too. Yeah, absolutely fascinating. What a terrible disease. Yeah. And I don't know, are there any questions?
So there are a few. Sanjay, I'll just make the first one live.
Is there a link between hepatitis C and mucor? I don't know of a link between hepatitis C and mucor. Dr. Madan, if you could comment as well, but that's a very specific question. So I don't know if there's some data behind it, but it's not something that I've certainly seen here in Australia.
No, I agree with you. I don't think we have seen hepatitis C particularly related to causing any, posing as a risk factor for mucormycosis. I don't think so.
And next question, what is the prevalence of mucor in tropics versus the temperate zones? I haven't got those data at my fingertips. Now, if you look at a place like Australia, We can look at Darwin in the north, which is tropical, and most of the big cities in the East Coast, those areas which are temperate. But we have so little mucor here. As I said, 70 odd cases found between 2004 and 2012, that it's very hard to see a difference. Dr. Madan, I guess India's a big country with different regions. Are there any obvious regional differences?
Very difficult to comment on this. Last year we thought on this line, because the way we saw mucor in Western India, that is Gujarat and Mumbai, and southern parts of the country. The Northern India and Eastern parts did not report too much. But this time, for last 2-3 months, we are getting reports from equivalently from almost all the parts of the country. So right now, I don't think there is within the country there are any major differences. Of course, the absolutely cold parts, that is the northern states like Jammu and Kashmir and Himachal and all, there are not much reports. But apart from that, we are getting reports from each and every part of the country at present. So we have seen it everywhere this time. In my center, in the last 2 months, we have seen close to 95 cases, starting from April, if I say, just COVID-associated mucormycosis, which is much more as compared to the last year.
So in 2 months, you've seen more than all the cases we saw in Australia in 8 years. So there you go.
Yeah, I know. Yeah.
That puts it in perspective. Next question, we find mucor in patients who work with soil. Might that be the reason you see it more in mainly agrarian countries? Yeah, look, I must say, I have to ask some of my Sri Lankan colleagues how much mucor they see. I don't know if they see as much as is seen in India. Look, certainly being outdoors and in the soil, you'll get exposed to these. But in Australia, there are people love to garden, use potting mix. It's a very common pastime. So I think you need to get exposed to mucor. You need to have it in your system for you to get sick with it. So that could explain the exposure. But in terms of clinical disease, there are those other risk factors. And as we talked about in India, diabetes, uncontrolled diabetes seems to be a big issue. Whereas in Western countries like Australia, it's immune compromised due to hematological malignancies. That's really the main issue. Yes, you briefly discussed the surgical removal of necrotic tissue and amphotericin. Are there any other pharmacological, non-pharmacological approaches which are currently under trials being investigated for their efficacy? And wants to ask Dr. Madan as well for her perspective. So at the moment, I don't know of any specific randomized controlled trials. As I said, there haven't been many randomized controlled trials in this field of mucormycosis. Certainly other treatments have been talked about, even calcineurin inhibitors, because they seem to have some of them seem to have some anti-mucor activity. But I don't know if that's translated into trials. Similarly, the use of statins, I don't know if that's made its way into any trials. In the past, people, and I don't know if this is still done in India at any centers, Dr. Madan, GM-CSF was, when I was training, occasionally those types of agents were used for mucormycosis to stimulate the white cells as a part of treatment, but I don't think the studies have borne that out at all. Hyperbaric therapy is another treatment, so hyperbaric oxygen therapy, but again, I don't think there's any clear-cut outcomes with that. So yeah, really, that's probably all I can comment on. Dr. Madan, is there anything else?
No, I think apart from the main antifungals, that is amphotericin B, posaconazole and isavuconazole, what we have been using is deferasirox. So that drug we are using, So we are using in those patients where the source control, that is the surgical debridement, cannot be done to a very good extent. Patients who have involvement of the skull base or the involvement of, involvement in the brain. So in those patients where we know we cannot do a good satisfying surgical debridement, there we use deferasirox for these patients. Another thing which Yeah.
Please go ahead. Please go ahead.
Apart from the medical treatment, we have been routinely using retrobulbar amphotericin B for our patients who have got involvement in the, just like involvement of the periocular muscles, or, when we see that the fungus has already reached the orbital apex and the vision is 100% preserved. So there we try to preserve the eyes, and this seems to be a very good approach. So we are building our data on retrobulbar amphotericin B, and it seems to be doing really well. We have been trying to save a lot of eyes. Yeah.
Well, I was just going to ask, what dose do you use of retrobulbar amphotericin?
They use I don't remember exactly, but it's a minimal dose. I mean, they just take, I think, 0.5 ml of amphotericin B after diluting it in the 10 ml of 50 mg. They dilute, the surgeons, they dilute in 10 ml of distilled water, and then they take 0.5 ml of that. So that comes to somewhere around, yeah.
And I think I mentioned earlier that randomized controlled trial with amphotericin B and desferrisox, which didn't go very well, but it sounds like in your center, it seems to be working quite well, associated with good outcomes, do you think?
Yeah. So we published a study from Hinduja Hospital, Mumbai, in which we showed that desferrisox, it was basically a case series of a few patients, but it seems to be working well in those patients where surgical, it doesn't seem to be a case in all the patients. We don't use it in all patients, only where we are not sure of the source control, proper source.
Okay, fantastic. And yeah, as I said, that study where the outcomes were poor, it could have been because the patients who were given the agent were actually very sick patients, sicker than those of placebo.
Yes, that was a bias in that study.
I think so, yeah. Look, those are all the questions. So I might, if Dr. Madan doesn't have anything more to add, I might hand things back to our moderator, Dr. Talalika.
Thanks, Sanjaya. I think there was somebody from the audience had raised their hand. Could I get you to please put in your question through the Q&A box, and meanwhile I'll try and start wrapping up. We have gone over time a little bit, but the discussion we've had between Sanjaya and Surbhi has just been so interesting that I'd like to give the audience the opportunity to ask more questions if they'd like to. But in the meantime, can I thank you both for the excellent presentation and discussion we've had so far on a topic that's affected so many people in India. As you know, we've recorded this talk, and with your permission, we'd also like to feature it and share it with people from other countries, including Nepal, Malaysia, and Indonesia, where the number of COVID cases now has started spiking, as opposed to India, where the cases have gone down for now. And I hope it stays that way. So I think there might be one more question if you are, there's a thank you from one of the audience members. So with that, let me thank you both again, and just put up a poll for the audience to participate in about the talk. We really appreciate the feedback that you give us. We'll use it to improve on our future webinars.